Okay, for our next speaker slot, could I welcome Tara and Hugh, if you're able to share your cameras, take yourselves off mic. Excellent. And you've been busy listening in for the whole event, haven't you? Which is great. So thank you for joining us. Tara, if you wouldn't mind introducing yourself to everybody, and then Hugh.
Sure, happily. And I've been doing a tiny little bit of tweeting as well. We've been going. I'm Tara Donnelly, and I am the Chief Digital Officer at NHSX. My background, though, has been in essentially running hospitals for many years. So I am quite an operational person. And for me, bringing together digital improvement and ops is a real sweet spot. So I've thoroughly enjoyed this morning.
And Hugh, if you wouldn't mind introducing yourself.
Yeah, thanks, Laura. My name's Hugh McCaughey. I'm the National Director of Improvement, and a bit like Tara, I've spent the vast majority of my career at the delivery end, probably about 30 years working in trusts. Most of that in Northern Ireland, where we had integrated health and social care trusts, which was a great opportunity, I think, because actually as a chief exec, you were managing the complete spectrum of care from the hospital right through to care going into people's homes or when people were placed in other forms of care. So it actually was a massive opportunity to be able to span the boundary in a way which, or you were, the boundaries weren't there, which made it a lot easier for implementation. But I suppose just to say, it's been I think it's been a fabulous morning, really exciting, and I love these types of things because that sort of seeing real examples, real case studies, led by people in many cases in the front line, supported by others, and it's I think the challenges for us is how do we take those innovations and make sure that we embed them in a way where not just the group of patients in that area or in that locality, the people that have done it, but we make it much more widespread. Sorry, somebody showing me my...
a little bit crackly, Hugh, yeah.
Okay, I'll see if sometimes if I raise the laptop up, it helps. Is that a bit better?
That sounds a bit better, yeah. Yeah, so maybe just following on from that, Hugh, how we take this best practice and scale it. That's exactly what the Innovation Collaborative and the Remote Management Scale programme is there to do. And what's come out from today's event throughout all of the presentations is digital transformation is as much about people, process, culture as it is about the tools and the technology. So what's for both of you your perspectives on how do we align digital and improvement now to harness this sort of best practice and scale it across the country to deliver transformative benefits for patients and citizens? Don't know who wants to go first on that one.
Will I kick off, Tara?
You're very welcome to, yeah.
Okay. It's funny, as I was listening, I mean, I did find it really stimulating this morning, and I made a huge amount of notes, and which was probably why I wasn't tweeting, Tara, but I will tweet later. But actually, as I started to try and connect it together, I sort of put a number of transitions I think we need to do, and a number of journeys we need to make, I think, to create the future that we want. The first of those, I'll just quickly run through them, but moving from, and what today has been about, moving from hospital to home, moving from a sort of form of institutional care and being able to keep people in their own homes. And all the stories today, and I would always start with the patient. I think Barry was for me, I distilled it into the 3 C's. Being able to, his concerns about leaving a hospital and going home without having people around them in the care, and those concerns were addressed. Having the confidence that anything he needed out of hospital could be delivered. And then the third C was the continuity that this delivers. So the fabulous example of the heart nurse ringing him up to say, you have one of these results off, and that being so proactive. What was before, when somebody goes home, they're out of sight, we have no idea of how they are.
but this continuity, so that we're actually monitoring people in real time, I think is fabulous. But it's shifting from the institution to home. I think there's something around how do we move from more healthcare to better health status. And it's that upstream thing, which is about being more proactive rather than reactive. So shifting from a reactive model where we're treating dependent, or we're sort of interacting when people become dependent, vulnerable, or ill. But actually, how can we get upstream and keep them well, keep them from becoming dependent, keep them independent? So there's that really being truly proactive. I think to answer one of the answers, the other shifts we need to make answers the question you've just asked me, which is how do we shift from silos and doing national programs, pushing things down in initiatives down into the delivery end, to be much more around how do we collaborate and create integrated packages or integrated initiatives. And I think a key bit of this is moving from programs to pathways. My experience as a provider was, you had somebody coming at you about, initiatives in digital, you had somebody coming at you about, outpatients, you had somebody coming at you about, GIRF, you had somebody coming at you about a NICE, you were getting 130 sort of safety notices a month. You have to sift all those and try and make sense of them and try and find ways to implement them. And the reality is you have a certain bandwidth. The more we can actually embed this into, here is the pathway for these types of conditions. And I think the examples I've just had, from Roma and Alison and Harinder, are actually around how these things are embedded into a pathway, an optimum way of doing something. And that will also help us to scale things. The other shift, I think, is moving from a paternalism, and I think Vin captured this a little bit, where he talked about how they being in charge of the patient and how being risk averse. But actually, when you move from that sort of the doctor taking the decision to this is something we do in partnership with the patient, it's empowering for everyone, the clinicians and the patient, and the experience is very different, as Barry outlined. And I think the sort of couple of last ones I will promise to finish was what I described as moving from the wildflowers to the ploughed field. The risk, I think, is we have a lot of innovations which sprout up all over the place, but we don't have a systematic way of really making sure that they embed, and that, I think, comes back to the pathways. And we need to be, the opportunities we've heard today, the initiatives we've heard today, imagine if every patient, we could implement that much more quickly so every patient benefited from it in every area. And that's what we've struggled with traditionally in the NHS. So we have to be much more, I think, systematic, and that's where pathways will be a real benefit. And one final thing, which is a sort of shift, which I think is about the culture. We celebrate innovation, and even today is about it's about the innovation collaborative, and that's entirely right. But I think we also need to encourage the behavior of harvesting. So it's back to my ploughed field again. But actually, what we want is people to be hungry to pull these initiatives in. We want a culture. We want to celebrate the culture where people are looking for, the examples we heard from the respiratory team, or in the care homes, or in the ECG initiative, so that people are wanting to pull that in, and that we're celebrating that. Bree talks about the pinch with pride. I think, I love the term, but which Maureen Bisignano coined, was around being harvesters of things that work. If we do that, then we will embed things much more quickly, and our patients will benefit and our staff will benefit.
Thank you for that, Hugh. Lots to pick through there. But Tara, do you want to come in?
Yes, sure. And I couldn't agree more with what Hugh was saying. So this is the 4th event I've been to, and I've so enjoyed the previous ones that I have to say my expectation was completely sky high, and I haven't been disappointed at all, because once again, we're hearing about incredible progress from when we last met, and people are so generous with sharing their practice with others. I would have loved, some of the information that Roma shared on her slides. As a service manager setting up services, I had to start from zero. I remember sometimes ringing people up from an HSJ article because it sounded like they were doing something vaguely similar. But, you know, the friction that involves, tracking people down. Whereas I think this is a community of harvesters sharing their work with such generosity just to help other people in the NHS do things a little bit more quickly and you know, not reinvent the wheel, but you know, business cases that people have shared. Some of the most, Donna talked about the 7,000 views and downloads. People are looking at really practical things like benefit cases, business cases, data sharing agreements. Brilliant. Let's just share the heck out of all of that because we haven't really got time to hang around here. Do find a moment to watch the Mary film. It's fantastic. And I think, as Hugh was saying, the way this feels to people is just amazing personalized care. The tech enables it, but it's not about the tech. It's about the relationship. And as Barry described, he feels like he's looked after all the time. There are 3 nurses looking after over 100 patients like Barry. Yeah. And yet he feels fantastically supported. He's not going to his GP as much. He's not being hospitalized. It's really good all round. And what's great, I think, is that the whole morning has been quite a celebration of some of these terrific stories and the feedback that we're getting from staff and patients alike. And it's now moving into how can we make it even better? You know, the interoperability piece. Do we look at slightly fewer platforms? I have to say that there's been a bit of chat about should we just have one national platform, and I really don't think that's the answer for loads of reasons. But also it's a mature market, the remote monitoring field. There are different products, and having competition between them will help keep standards really high. But it is the oil, isn't it? The data that we have about our patients is the oil that runs everything. So enabling greater interoperability is definitely a key task, and some people have cracked that really well. And I have to say that all the remote monitoring companies that we have linked into, because they're part of this partnership as well, are completely up for adhering to standards and so on. Sometimes it can be the bigger players who are less keen, but we're also having really strong conversations with them about just making this the right thing for patients. So, and then the final thing I just wanted to make reference to is the scaling. So I was looking recently at the whole system demonstrator, the telehealth research that was done some years ago. They looked after 6,000 patients there. This programme has already got digital home care to 205,000 people in every region across the country. This is scaling. Virtual wards is in an amazing place because it started with some visionary people, some of whom, like Bushra, we've seen today, and it has become an absolute mandated requirement for the NHS in the planning guidance that came out on Christmas Eve with serious money attached. So that is, we are watching something move into the mainstream that will make such an enormous difference to people. Vin talked about the deconditioning point, didn't he? You know, having worked in hospitals for about 30 years, they're great, right? If you're acutely unwell, that's where you need to be. However, they're pretty terrible the rest of the time. So if we can do more to help people recover in the comfort of their own home, but with supervision, that's has been said, a moral challenge, isn't it, to try and achieve that. So they're just a few thoughts from me about the morning. But Hugh.
Yeah, Laura, I mean, it's almost a challenge to everyone that's on the call. And I used to take a team every year away to the IHI BMJ sort of improvement conference, and one of the things we always did, we made a virtue of, was we would all take some learning back, but we all committed to do at least one action or connect with one other person that we felt could add value to work we're doing. So in a way, I throw out a challenge to everybody it's on the call. It's easy to go away, stimulate and learning, and then bang, you're back into, you know, today's and tomorrow's sort of pressures and work deadlines, etc. So, you know, my challenge would be, don't go away from here without making at least one connection and taking away one thing that you want to use. And whether, I mean, I would encourage people to stick that in the chat box, or even to, you know, to connect with one other person that you've heard from or that you're going to make a connection with, because it just does that wee bit of rigor, if you like, in terms of forcing ourselves to think about all that we've heard today. what are we going to use? Who are we going to connect with? And if we do, each of us, the 280 or 300 people that are on the call, that will increase the connectivity, and it's through that connectivity, that agility of the way we work, that really makes things happen. So I'd encourage people to do that before they finish today.
Absolutely, thanks for that, Hugh. And staying connected through the Innovation Collaborative, because we will be doing more of these events, and Breed's going to kind of sum up some of this towards the end of the session. Just one final question for you both, then that kind of came through the chat as well, was and building on what you said about taking a pathway approach, Hugh. In order to do that and to really reap the benefits of tech-enabled care, how do you work with clinicians to really identify the problems that need to be solved? Because these things aren't a panacea for everything, are they? So just any from using your sort of improvement expertise and tech transformation, how do we get really crisp definition of problems that clinicians are dealing with on a daily basis?
Yeah, I'd go back almost to one of the things Tim said right at the outset, and he mentioned the transformation engine, and at the minute it's very much in the sort of concept or idea stage, but I'd be very keen that we actually have an input from the Innovation Collaborative. I'll be wanting to get sort of an input from the Improvement Directors Network. I think there's a whole range of other people who I think should shape this. But the concept behind it is, how do we take, and that sort of moving away from the silos piece where we're working on a particular issue, there's a digital solution for, we're maybe working on something through a NICE recommendation, we're maybe working on something that's come up as an improvement somewhere. How do we take that into the transformation engine, where we take each of those inputs, the digital, the improvement, we have the clinical leads, we have the range of people that we need in there, that everybody has an input to make and a contribution to make in that sort of agile way. And they help us redesign the pathway with clinical leaders so that the crispness, as you say, of the problems are embedded into, and what comes out of the transformation engine is a sort of optimum pathway that's saying we should be having the virtual ward, we should be having Roma's sort of connection with care homes, we should be having the ECG deployment in these conditions and pathways. And then all the changes from the different points are embedded into the pathway, and it's the pathway then that we should be implementing. And one final point I did forget to make earlier was reinforcing, and what I really liked about the presentations, each of the presentations, and I made the point in the chat box, they all had assessed impact. And I think that's going to be critical for us moving forward. How do we forget about let's not forget about, but the outputs or the things that we produce, and think, what difference does it make to people's lives? How does it impact on their not just their experience, but their lives? How do we make their lives better? And that's how I think that's the goal in terms of where we need to get to in terms of impact.
Tara.
And just to add a couple of thoughts on that is, one of the ways that the regional scale work has been run has been to have tight elements and loose elements. So the tight bit has been that people have had to commit to uptake to a certain number of patients, because this is about scale. But the loose bit is that they've been given enormous freedom about the best way to do that. One of the things that has been so interesting is to see that where people have put in remote monitoring for perhaps one condition or a virtual ward for COVID or for respiratory patients, as soon as clinicians get these devices in their hands, they can instantly spot new opportunities. And we've seen that. We've seen kind of criteria being set quite narrow, perhaps slightly risk averse to start with. People gain the confidence, and then they see the possibilities locally. So I think that's a terrific explosion of innovation. But as Hugh says, we can learn from that, and we can learn from what works really very, very well to say, actually, this ought to become much more the norm. I think we're seeing that a bit in blood pressure monitoring at home, that actually all the evidence is pointing towards that is is a better way to manage your health than to be schlepping to a GP regularly. So there may be areas where we think, do you know what, the evidence is so strong here that a bit like, you know, the cancer 2-week wait criteria, we would go that this is the pathway that should be offered to everybody across the country.
Fantastic. We could stay for another hour, I'm sure, talking through all of this. And thank you both for your time, both in terms of this panel session, but also being with us for the whole morning. Everyone's really got a lot out of that, so thank you so much.